Okay, so I was trying to get that last line in there. Welcome back. Let's continue our talk about diabetes type 2. When we have these comorbidities together, they're collectively referred to as metabolic syndrome. We typically hear metabolic syndrome. Now we don't hear insulin resistance syndrome or syndrome X anymore. Then we can have what's called hyperosmolar hyperglycemia syndrome. Hyperosmolar hyperglycemic syndrome used to be referred to as hyperosmolar non-ketotic syndrome. So you might hear some people refer to it as HINKS, HHNKS. It's the same thing. We just have changed the name to make it more clear. And it occurs with type 2 diabetes as well. Because the patient has some endogenous insulin, sometimes no ketosis develops. So without the ketosis, they don't have any ketones. So that's why it's called hyperosmolar hyperglycemic syndrome. The blood sugars in these patients can be greater than 800, up to 1,000, and even more. So when we have this problem, ironically, the mortality rate can be as high as 20%, which is higher than the mortality rate seen with diabetic ketoacidosis, but it doesn't occur as often. So the clinical outcome for HHS and the prognosis are determined by the age of the patient, the degree of dehydration that they have, because they usually have some dehydration going along with it, and whether or not they have other comorbidities. So what can happen is the patient goes into a hypovolemic shock. So typically you're going to see HHS syndrome, or this hyperosmolar hyperglycemic syndrome, in an older patient in the 5th or 6th decade of life or older. You're going to see the younger patients usually with DKA. So and there is a disproportionately high number of African American, Native American, and Hispanics who develop hyperosmolar hyperglycemic syndrome. So that could be because of the high prevalence of this group of them having diabetes, but it can particularly be fatal in the morbidly obese African American male. So those are just some of the genetic research studies that are being done now that are leading us to more information about ethnicity related to our disease processes. So what's really happening that this is having such a higher mortality rate and having more problem is that although the insulin is still being, because the insulin is still being produced by the beta cells, the generation of the ketone bodies is minimal in these patients. So the ketogenesis just doesn't occur. And so the acidemia is then pretty mild. But the effect of this increased serum osmolarity in the brain is the problem. To preserve the intracellular volume, the brain produces an idiogenic osmoles. And these idiogenic osmoles are substances that are osmotically active. So the effect of these substances is to prevent fluid from moving from the intracellular space into the extracellular space and maintain a balanced equilibrium. The problem then is that there is the risk of developing cerebral edema. So it's related to how fast the serum osmolarity is decreased. If the decline is too rapid, the brain's not able to eliminate those idiogenic osmoles at the same rate as the decline in the serum osmolarity, then the chances of the fluid moving into the brain cell and causing swelling are higher. So the goal of treatment for HHS is actually to slow the correction of hyperglycemia with these huge blood sugars of 800 and greater, or high blood sugars, huge but high. So this hypovolemic shock, these renal problems occur, patient can have stroke, coma, and resulting death. So not as common, but pretty high risk. With metabolic syndrome, we see these set of risk factors, and they typically have a central abdominal adiposity. So men's waist size that are greater than 40 inches and women's waist sizes greater than 35 inches, we know are a risk factor. Fasting triglycerides greater than or equal to 150 milligrams per deciliter. A high-density lipoprotein cholesterol, or HDL cholesterol, less than 40 in men and less than 50 in women. So remember, high density is our good cholesterol. They'll also have usually blood pressure greater than or equal to 130 over 85, 130 systolically and 85 diastolically. We will see fasting glucose that's greater than or equal to 110. And they also then possess prothrombotic and pro-inflammatory tendencies. Now, I was reading literature, and I know your textbook has some numbers, but in the United States, 20% of the adults, 47 million people, have metabolic syndrome, with a prevalence approaching 50% in the elderly. And it's seen more often, obviously, in those who are overweight. But in the United States, what I just read was that the prevalence in the adult 18 plus population has increased by 35% from 1980 to 2012. Now, a report that was just published in January of 2019 by the National Institute of Health indicated that 85% of those with type 2 diabetes have metabolic syndrome. But fortunately, a study from the National Health and Nutrition Examination Survey is showing that the prevalence is starting to decline. I think that that's because we understand that the root cause of metabolic syndrome and diabetes mellitus type 2 is poor eating habits and a sedentary lifestyle. And so we're starting to see a real push to preventive medicine and to changing that with our diets and our exercise and health coaching and other types of wellness-centered care. So that's a good thing. When we look at metabolic syndrome, we know that everything is related. These things are interrelated. The obesity and lack of exercise tend to lead to insulin resistance. So the insulin resistance has a negative effect on lipid production. So we increase the VLDL, the LDL, and the triglycerides. This lack of exercise decreases the HDL. We need to make the HDL by exercising. The insulin resistance then leads to increased insulin and glucose levels in the blood, and the increased glucose and insulin in the blood affect the kidneys by holding on to the sodium, which then increases the blood pressure, and so we can have hypertension. So also these chronically elevated blood glucose levels then damage the blood vessels and the organs and increase the hypertension, the peripheral vascular resistance. So it's just all of these things that are related that cause this metabolic syndrome that lead to really poor outcomes for the patients with diabetes. So let me just give you a few more statistics. So 7 million people in the United States are unaware that they actually have diabetes, it's estimated. We'll talk about gestational diabetes, but it affects about 5 to 10% of all the pregnant women in the United States each year. Diabetes is considered the 7th leading cause of death, and the risk of death among people with diabetes is twice that of people of similar age without diabetes. It is the leading cause of blindness in adults, and diabetes is responsible for 60% of the non-traumatic lower limb amputations, with over 65,000 amputations performed each year on patients who have diabetes. So those are some stunning statistics, and we have to help turn those around, right? Because we're nurses, and that's what we do. So let's go on. Gestational diabetes. This is the hyperglycemia that develops during pregnancy. Now, insulin has to be given to prevent birth defects. This usually subsides after delivery, but 30% of patients with gestational diabetes, it's estimated, go on to develop type 2 diabetes within 10 to 15 years. Let's talk about some more age considerations, age-related considerations. Type 1 diabetes mellitus in children, they need a consistent diet, blood glucose monitoring, insulin injections, and exercise. These kids learn really well, really early how to manage their diabetes. But that blood sugar control is essential to maintain normal growth and development, because remember, growth hormones increase right? Blood glucose levels. So the other thing that happens is that infection and illness is more common, and particularly infections in the diabetic patient. And so in children, their exposure is more significant. So they can have wide fluctuations in their blood sugar levels because of the infection or illness, thus resulting in greater risk for poor outcomes. Children are more highly susceptible to dehydration. We know that to be because of their body composition. The rotation of sites is very important because of the muscle can be damaged and the lack of fat. If we have a child who is healthy and not an overweight, we don't have a lot of subcutaneous tissue necessarily. So rotation of the sites is very important. And we want to avoid hypoglycemia. That's a real major goal in infants and young children, due to the damaging effects on their growth and development. Remember, these little folks are still growing with glucose. That's how they grow, is that sugar that's readily available. So let's just give you a quick list of type 1 diabetes signs and symptoms in children. Hypoglycemia, hunger, sweating, tachycardia, irritability, and lethargy. Now, what about screening for diabetes? Well, prediabetes is a category of increased risk for diabetes. And at this point, you have a hemoglobin A1C between 5.7 and 6.4. So we're looking at fasting plasma glucose levels higher than or equal to 100, but less than 126. So they may get an impaired glucose tolerance test or an oral glucose challenge. Screening is recommended every 3 years for all patients who are 45 years and older. And it's usually an A1C that we're doing an in-office finger stick. So not an expensive test, not a test that's unreasonable to do, along with their regular screenings that they're going in for. Other age-related considerations, when we look at the older adults, we want to have very close monitoring of blood glucose levels. Visual impairment may affect their ability to self-administer medication. And remember, the number one reason for adult blindness in the United States is diabetes. So as a complication of diabetes. They could also have renal insufficiency. So caution with certain medications is really a concern. And caution with metformin, particularly if they have renal impairment. The glitazones, we'll talk about those in a little bit, can predispose the patient to fluid retention, thus leading to heart failure, which our patient is already at risk for if they're an older adult. So let's talk for a minute about non-pharmacologic treatments and interventions. We know that type 1 are always going to require insulin therapy. There is no oral antidiabetic agent that's going to work for them. They will require insulin therapy. A lot of times they can use a pump. They can get an insulin pump. There's different types of therapies now that are available. And so lots of progress have been made. Great strides have been made in this area. But with our type 2 diabetics, we want to talk to the patient about weight loss. We want to improve their dietary habits. If they're a smoker, we want them to stop and get them the tools and resources that they need to help them with their smoking cessation program. We want to reduce alcohol consumption. Of course, alcohol is empty calories, right? And then we want to encourage regular physical exercise. So it's important that the provider work with the nurse to help the patient set up a program, whether that is a structured program with a health coach or with a wellness coach or someone who can help them get on a regular exercise regimen. That's an important part of the process as well. Now, what are the glycemic goals of treatment? Well, we want the hemoglobin A1C to be less than 7%. The A1C diagnostic criteria, remember, greater than 6.5 is type 2 diabetes. 6.4 down to 5.7 is prediabetes, and anything below 5.7 is considered normal. So you will get patients that will come to the office or they'll come to the hospital or whatever environment that you're working in, and sometimes they'll have that hemoglobin A1C of 14. So often the provider will want to immediately put them on some insulin just to get their blood glucose down because of the incredible damage that can occur as a result of these high levels of blood glucose. So that doesn't necessarily mean that